We often hear about the dangers lurking in our carotid arteries, mostly, blockages leading to strokes.
Right, that's the common narrative.
But today, we're plunging into something far less common, yet really significant when it happens. Extracranial carotid artery aneurysms.
Yeah, ECAAs, yeah.
Think of it like this. Instead of a narrowed pipe, it's a bulge in one of those main blood vessels supplying your brain, but outside the skull.
Mm-hmm.
While carotid stenosis, that narrowing is relatively frequent, these aneurysms are definitely the exception.
Very much so.
Now, what exactly is an aneurysm? Generally, it's defined as an artery swelling to 50% larger than its normal size.
That's the basic idea.
But when we're talking carotid, some experts, like de Jong and his team, they suggest a more precise measure.
Yeah, a bit more specific.
Like a bulge in the carotid bulb that balloons to more than twice the diameter of the internal carotid artery, or maybe 1.5 times the diameter of the common carotid.
Exactly. It shows you there's nuance even in the definition.
It really does.
And that's a really important point, that nuance. It just highlights how unique these extracranial carotid artery aneurysms, these ECAAs, really are.
So our goal today is to really dig deep into this pretty uncommon issue.
That's the plan. We'll be using chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, a major authority in the field.
A gold standard source.
Definitely. So we'll use that as our guide to understand, well, what triggers these aneurysms, how they show up, the methods used to diagnose them, and, of course, the treatments available.
So a really comprehensive look at something that doesn't grab headlines often, but is critical when it pops up.
Precisely.
Okay, let's get started by looking back a bit. History. It's always eye-opening to see how things changed.
Always.
Back in the early 1800s, Sir Astley Cooper, he did some of the very first surgeries for these bulges.
Yeah.
Though, well, the outcomes were pretty varied.
Yeah, varied is putting it mildly, I'd imagine.
Right. The main treatment back then was basically just tying off the common carotid artery ligation.
It sounds pretty drastic.
It was. And as you can imagine, it came with a huge risk. High mortality rates.
Makes sense. Cutting off major blood flow to the brain.
Exactly. It wasn't until the mid-20th century that surgeons started shifting towards actually removing the aneurysm and then, repairing the artery. Reconstruction.
A big leap forward.
Then, fast forward to the 1990s, and we see endovascular techniques starting to emerge.
Which really changed the game again, offering less invasive options.
It just shows that evolution, from understanding the carotid's vital role, even crudely, to these drastic early attempts, and then finally refining surgical and endovascular approaches.
And what's fascinating about that shift isn't just the tools improving, it's also the deeper understanding of the condition itself.
How so?
Well, early on, they were just trying to stop the pulsation or bleeding.
Right.
Because they couldn't see inside well.
Makes sense.
But moving towards resection and reconstruction showed a desire to actually restore normal blood flow, not just stop the problem. And endovascular methods gave a less invasive way to do that, especially for aneurysms that were, hard to get to surgically.
Okay, so let's talk about who gets these and why. The causes. It seems like the reasons have really changed over time.
They absolutely have. Before we had widespread antibiotics, infections were a huge factor.
Like what kind of infections?
Things like syphilis, tuberculosis, even really common stuff like ear or throat infections. These were major culprits, especially in younger adults, say in their 20s to 40s.
And these led to what are called mycotic aneurysms.
Exactly. Often pseudoaneurysms really contained ruptures caused by the infection eating away at the vessel wall.
So the key takeaway there is this massive shift from infection, which antibiotics largely tackled, to more degenerative causes now.
Precisely. That demands a totally different approach, focused on managing chronic vascular disease.
So what are the main causes today?
Well, with infections less common for this specific problem, the main drivers now are more related to, let's say, wear and tear and other medical events. Atherosclerosis, that plaque buildup, is a leading factor now.
Especially in older men.
Yeah, typically men over 60. Then there's trauma. That could be a penetrating injury like a stab wound or blunt force to the neck. That tends to affect younger people. And we also have to consider pseudoaneurysms that can pop up after a carotid endarterectomy, the surgery to remove plaque. Those usually show up later, maybe 6th or 7th decade.
And are there other less common factors?
Definitely. Things like previous head and neck surgery or radiation therapy to the area, those can play a role. And certain connective tissue disorders, too, like Ehlers-Danlos or Marfan syndrome, they weaken the tissues generally.
When you look at the numbers, just how rare are these?
They're really quite rare. A review up to 1977 found only about 850 cases reported in the literature.
Wow.
A more recent review, covering 1900 to 2014, found around 1,200 patients. Now, that is an increase.
But likely because we're better at finding them now with imaging.
That's almost certainly the main reason. Better imaging catches things we might have missed before. It's not necessarily that they're happening that much more often.
That's a critical distinction.
Absolutely. High-resolution ultrasound, CTA, that's computed tomography, angiography, MRA, magnetic resonance angiography. These tools let us spot them much more easily.
And in actual surgical practice, how often do surgeons see these?
It's pretty uncommon. Repairs for these ECAAs only make up something like 1 to 2% of all carotid procedures. Really highlights their rarity.
So let's dig into how these different types actually form. The pathogenesis. Atherosclerotic ones. Sounds like a gradual weakening.
That's right. Atherosclerosis just sort of progressively damages the artery wall. These aneurysms are often fusiform, kind of spindle-shaped, bulging out evenly.
Then where do they usually show up?
Typically at the carotid bifurcation where the common carotid splits and in the proximal part of the internal carotid artery, the ICA. If you looked under a microscope, you'd see breakdown of the elastic layers, thinning of the muscle wall, basically structural failure over time.
And saccular ones, the pouch-like ones.
Those can sometimes pop up with severe high blood pressure, even if atherosclerosis is still the underlying problem, more of a distinct outpouching.
Okay, and the traumatic ones, that sounds more like a direct hit.
Exactly. Penetrating injury, blunt force, it directly damages the artery wall, leading to a pseudoaneurysm that contained leak.
Any other causes of trauma?
Well, iatrogenic injuries, meaning caused by medical procedures, can happen, like during attempts to place a central line catheter in the nearby jugular vein.
Oh, okay.
And there's also a risk after blunt cerebrovascular injury, BCBI, usually affects the ICA higher up near the skull base. These traumatic tears or dissections can sometimes evolve into pseudoaneurysms too.
Then there are the post-CEA ones. After the endarterectomy surgery, what goes wrong there?
Usually it's a problem with the suture line where the artery was closed, or maybe the patch used to widen the artery breaks down. Infection can also be a major player.
Infection again.
Yeah. Historically, sometimes the old silk sutures would actually degrade. And infections, often staphylococcus, can definitely weaken the repair site. We've even seen vein patches themselves become aneurysmal.
Wow. And finally, you mentioned arterial dysplasia like FMD, fibromuscular dysplasia.
Right. FMD is a condition where artery walls develop abnormal cell growth, often in the kidney arteries, but also the carotids.
Giving that beaded look on scans.
Exactly. That abnormal structure weakens the wall. In the ICA, it can sometimes lead to a dissection, which then can turn into a pseudoaneurysm.
It's interesting, the textbook notes that even though atherosclerosis is common, it might not be the only factor in these ECAAs.
That's a really key point. While the microscopic features often look like atherosclerosis, fragmented elastic layers, fatty deposits, the fact that these aneurysms are so much rarer than just standard carotid narrowing suggests other things must be contributing to that specific weakening and dilation. It's not just plaque buildup.
So how do these actually show up? What symptoms might make someone or their doctor think about an ECLA? What are the red flags?
The most common thing by far is a painless pulsating lump in the neck. One big study found that was the first sign in over 90% of cases.
Pulsating, like you can feel the heartbeat in it.
Exactly. Now, if that lump is also tender or the skin over it is red, especially with a fever, that screams possible infection. Mycotic aneurysm.
And does the location change how it appears?
Absolutely. Aneurysms high up in the internal carotid, they might actually present as a pulsating mass way back in the throat in the tonsil area.
With no neck swelling.
Sometimes very little or none externally. The muscles and tissues kind of push it inward, so a persistent swelling back there, even without obvious neck swelling, should raise suspicion. ENTs often spot these first.
Whereas ones lower down near the bifurcation.
Those are usually much easier to feel as a neck mass.
What about brain symptoms? Neurological stuff, big concern, right?
Huge concern. Neurologic events can definitely be the first sign. Anything from TIAs, transient ischemic attacks, those mini strokes.
Like temporary vision loss or weakness?
Right. Or full-blown strokes. Usually it happens because clots form inside the aneurysm, break off, and travel up to the brain. Embolism.
Makes sense.
Larger aneurysms could also potentially press on the artery and reduce flow, but embolism is the main worry. Interestingly, TIAs seem to happen about twice as often as strokes in these cases.
So, for you listening, an embolism is just a bit of material, like a clot, breaking loose and blocking a vessel downstream.
Exactly.
And can these aneurysms mess with the cranial nerves, too?
Yes, they can. It's more common with aneurysms higher up, the distal ICA ones, but even larger ones lower down can compress or irritate nearby nerves.
Leading to what kinds of symptoms?
Things like Horner syndrome that affects the eye and face, drooping eyelid, small pupil from pressure on sympathetic nerves, hoarseness if the vagus or recurrent laryngeal nerve is involved, even severe facial pain from facial nerve compression.
Are there any other, maybe less frequent symptoms?
Occasionally, a really big aneurysm might press on the esophagus, causing trouble swallowing dysphagia. That could be just the mass effect, or nerve compression affecting swallowing muscles.
And rupture. Bleeding.
Fortunately, that's rare now, but it's incredibly serious when it does happen, especially with infected aneurysms or in patients who've had prior neck surgery or radiation.
That sounds like the carotid blowout situation.
Exactly. Carotid blowout syndrome, very high risk there due to infection, maybe the artery being exposed, tissues weakened by radiation. A dangerous scenario.
So, if a doctor suspects an ECAA based on these signs, how do they confirm it? What's the diagnostic process?
Well, the first step is usually duplex ultrasound. It's non-invasive, uses sound waves, and can often see the aneurysm and check the blood flow.
But it has limitations.
It does. As we said, it can miss those aneurysms really high up in the neck, the distal ICA ones.
So what's next then?
For a more detailed look, or if ultrasound isn't clear, then it's usually CTA or MRA. Computed tomography angiography or magnetic resonance angiography.
What are the advantages of each?
CTA is great for showing the bony anatomy around the aneurysm, really important for surgical planning, figuring out if it's in a tricky spot to reach.
Okay.
MRA can be better sometimes at telling old blood clot from new clot inside the aneurysm, which is useful if you suspect a dissection.
And they can look at brain circulation too.
Yeah, both can give valuable info about the circle of Willis, that network of arteries at the base of the brain, and collateral flow, the backup routes for blood supply. Crucial information.
It sounds like diagnosis has evolved too. Catheter angiography used to be standard.
That's right. Sticking a catheter in an artery, injecting dye, taking x-rays. It gives amazing detail for planning surgery.
But it has risks.
It does. A small but real risk of causing a stroke. So now it's generally saved for when you're actually planning an endovascular intervention, using catheters to fix the problem.
Or in rare cases where other options aren't possible.
Exactly. Maybe if ligation tying off the artery is being considered as a last resort.
And speaking of ligation, what about that balloon occlusion test and stump pressure?
Ah, right. Those are tests sometimes done before considering ligation.
How do they work?
With the balloon occlusion test, you temporarily inflate a tiny balloon in the internal carotid artery while the patient is awake, basically blocking it off. You watch carefully to see if they develop any neurological symptoms.
To see if they can tolerate the artery being blocked.
Exactly. At the same time, you can measure the blood pressure in the carotid beyond the balloon, that's the stump pressure. If it's above a certain level, it suggests they have good collateral flow, good backup routes.
But these tests aren't foolproof.
Not at all. They can be inaccurate in maybe 10–20% of patients. Even if someone passes the test, there's still a risk of stroke or death after permanent ligation.
Why is that?
Could be the collateral flow wasn't quite good enough long-term, or clots can form in the stagnant blood in the tied-off artery and travel downstream. Thromboembolism.
Which is why anticoagulation blood thinners are so vital after ligation.
Absolutely crucial.
Okay, let's shift gears. What happens if these aneurysms are just left alone? What's their natural history?
Well, historically, the thinking was pretty aggressive. Studies suggested a high risk of TIAs, strokes, rupture. So the approach was generally to treat almost all of them once found.
But that thinking is changing.
It is, somewhat. Remember how the causes have shifted? Degenerative ones, post-procedural ones, they tend to behave more, let's say, benignly than the old infectious or traumatic types.
Okay.
Plus, we have better medical treatments now, statins, antiplatelet drugs like aspirin, anticoagulants, and better imaging to just watch them closely.
So for some patients, watching and waiting might be okay.
For carefully selected patients, yes. Particularly maybe high-risk patients with small, true aneurysms. A Mayo Clinic series showed that managing small ECAAs medically with regular scans resulted in no major complications or need for later intervention over a good follow-up period.
That's a pretty significant shift. So it's not always an immediate rush to treatment.
Not necessarily anymore. The decision is complex. It really depends on things like the size. Is it growing? Is it causing symptoms? What's the cause? The patient's other health issues. Where exactly is it? Is there clot inside?
Lots of factors.
Many factors. The general agreement now seems to be intervention is usually warranted if it's enlarging, bigger than about 2 centimeters, if it's infected, looks like it's forming clots or causing symptoms.
And for the small asymptomatic ones.
Especially in older patients who might be poor surgical candidates, careful observation with serial imaging might be a safe and reasonable path.
And to help classify these in planned treatment, there's the ADAGA classification.
Right. It basically categorizes them based on location, which helps surgeons choose the best approach.
So the main takeaway for you listening is that this classification helps surgeons pinpoint the bulge, which is key for deciding how to fix it surgery or maybe less invasive methods.
Exactly. It divides them into 5 types based on where they are along the common and internal carotid arteries. Type 1 is just above the bulb. Type 2 is longer ICA. Type 3 involves the bifurcation. Type 4 is extensive CCA. And Type V is isolated CCA. It provides a standardized way to describe them.
Okay, so let's say we've diagnosed an ECAA and decided treatment is needed. What are the options on the table today?
The primary goal is always to prevent neurological problems, stroke mainly. We do that by excluding the aneurysm from blood flow and restoring normal flow through the artery.
And the choice depends on the patient and the aneurysm.
Absolutely. Tailored approach. Location, size, cause, patient's overall health all play a role. We basically have 2 main camps. Traditional open surgery and the newer endovascular therapy.
Let's start with open surgery. What's the standard approach?
For many of these, especially in the common carotid or the beginning of the internal carotid, it's resection and reconstruction.
Meaning?
Opening the neck, carefully finding the aneurysm, removing the diseased segment, and then putting the artery back together somehow.
Sounds complex.
It can be, especially if the aneurysm extends high up the ICA, getting access and control is challenging. Might need special maneuvers.
And risks.
Well, the big one unique to neck surgery is potential injury to cranial nerves. Control swallowing, voice, tongue movement, etc. Reported rates are maybe 4% to 20%. Most are temporary, but it's a concern.
And during the surgery itself.
You have to be really careful not to manipulate the aneurysm too much before you have control of the blood vessels above and below it. Don't want to knock any clots loose.
Right. So after you remove the aneurysm, how do you fix the artery? What are the reconstruction options?
A few ways. If it's a small saccular aneurysm with a narrow neck, maybe just primary closure with stitches, possibly adding a patch. If the artery is kind of redundant or tortuous, you might be able to free it up, excise the bad part, and sew the ends directly together, end-to-end anastomosis.
But often you need a graft.
Often, yes. An interposition graft. That's a piece of vessel used to bridge the gap. Ideally, autologous using the patient's own vein, usually the saphenous vein from the leg, especially important if you suspect infection.
And for true aneurysms, you take out the whole segment?
Generally, yes. Replace the entire diseased, weakened section. For post-CEA pseudoaneurysms, you cut back to healthy artery wall and usually redo the patch, maybe using vein if infection's a worry.
You mentioned patches used in the original CEA. How do those factor into these pseudoaneurysms later?
Yeah, patching is standard now in CEA to prevent restenosis. They use Dacron, PTFE, pericardium. When a pseudoaneurysm forms later at a patch site, it's now more often linked to infection than the patch material just failing, although that can happen.
Dacron seems common.
Dacron patches seem to be involved more frequently in these infected pseudoaneurysms, sometimes linked to older suture types or just an infection settling there.
What about the actual surgical steps? Any specifics for these aneurysm repairs?
Well, like standard CEA, you need to monitor brain function while the carotid is clamped. EEG, maybe using a temporary shunt based on stump pressure measurements.
Some pressure again.
Yep. General anesthesia is preferred. Getting exposure for high or large aneurysms is the tricky part. Might need to extend the incision, divide muscles, tie off vessels, remove the styloid bone, maybe even temporarily dislocate the jaw.
Wow, serious measures.
In tough cases, yes. Sometimes small balloons inside the vessel help control bleeding from far ends. Once exposed, you decide, full resection or partial. There's a technique, endoaneurysmorraphy, where you leave the sac and wrap it around the graft might reduce nerve injury risk.
And fixing those prosthetic patch pseudoaneurysms?
Key is removing the bad section back to healthy tissue, often using vein for the repair. Using a temporary straight shunt during vein grafting helps get the length right. An intraoperative ultrasound at the end is really valuable to check the repair.
What about ligation, tying it off? Is that ever done now?
It's really a last resort for ICA aneurysms now, thanks to better reconstruction. Maybe in an emergency like rupture with infection where repair isn't possible. Or sometimes for isolated ECA aneurysms, the external carotid.
And if you do consider ICA ligation,
Definitely need that preoperative balloon occlusion test, remembering its limits. And post-op anticoagulation is crucial to prevent clots. Heparin, then warfarin, maybe for a few weeks to months.
any other older techniques?
Yeah.
ECIC bypass.
Wrapping. Yeah, things like ECIC bypass, wrapping the aneurysm with tissue or mesh. They've been described but are largely abandoned now. Didn't really show consistent benefit or stroke reduction.
Okay, let's shift to endovascular therapy, the less invasive route. What are the big pluses here?
The main advantage is avoiding that big neck incision and all the dissection, especially for high aneurysms. This significantly lowers the risk of cranial nerve injury.
Which can be a real issue with open surgery.
It can. Even temporary nerve issues can be problematic, and permanent ones, though rare, can be debilitating. Endovascular approaches largely avoid that specific risk.
So what are the specific endovascular tools or techniques used?
There's quite a range. Placing bare metal stents, sometimes combined with packing coils into the aneurysm sac through the stent mesh.
Okay.
Double stenting one inside another has been tried, sometimes stents covered with the patient's own vein. Blocking the aneurysm directly with coils or balloons is another option. And then there are covered stent grafts.
So essentially different tools for different situations. Some just prop the artery open, others actively seal the bulge.
Exactly. The choice depends very much on the aneurysm's shape and location.
What about injecting thrombin, that clotting agent? You mentioned it for leg pseudoaneurysms. Does that apply here?
It's very effective in the femoral artery, guided by ultrasound. There's maybe one case report of using it in the carotid, but it's generally not done. Big concern about the thrombin potentially embolizing to the brain when you release the balloon used to temporarily stop flow. Too risky.
Got it. So back to the stents. How does transstent coiling work?
Okay, so for saccular aneurysms, those pouch-like ones with a neck, you first place a self-expanding stent, like a mesh tube, across the aneurysm's opening.
Like scaffolding.
Exactly. Then you navigate a tiny catheter through the stent's mesh into the aneurysm sac itself. And you deploy soft platinum coils to fill the sac, promote clotting, and block flow into it. The stent acts like a fence, keeping the coils packed inside.
And for fusiform aneurysms, the spindle-shaped ones.
For those without a clear neck, a covered stent graft is often better. It's a stent with a fabric covering, like PTFE. When deployed across the aneurysm, it basically relines the artery, excluding the bulge from circulation.
What are the requirements for using those?
They usually need larger delivery systems and, importantly, healthy artery sections or landing zones above and below the aneurysm for the graft to seal properly. And technically, they aren't FDA approved specifically for carotid use, though they are used off-label.
What about that double stent idea?
The theory is that layering two uncovered stents might slow flow enough to cause the aneurysm to thrombose or clot off. But there's a worry that if it doesn't clot completely, it might be hard to get back in later to add coils if needed.
And then there's TCR, transcervical carotid approach with flow reversal.
Yeah.
That sounds different again.
It is. TCR involves a small cut in the neck to directly access the common carotid artery. Then a special system temporarily reverses blood flow away from the brain during the stenting.
What's the benefit of that?
Couple of potential advantages. You don't necessarily need to predilate the artery or navigate wires and filters past the aneurysm or clot to place the stent, and it might be safer for distal aneurysms where there isn't much room to deploy a standard embolic protection filter.
Has shown good results.
Studies like Roadster showed pretty low stroke and death rates compared to traditional transfemoral carotid stenting. Often uses the NRUT system with a Viabon covered stent.
So with all these open and endovascular options, how do you choose?
Location and size are still critical. Endovascular is often preferred for large aneurysms or those high up the ICA where surgery is really tough.
Makes sense.
On the other hand, if there's a lot of unstable clot inside or the patient's already had emboli, open surgery might feel safer to directly remove the source. Also, very twisty, tortuous arteries can make endovascular navigation difficult. In those cases, open resection and maybe a direct repair might be better.
Okay, let's talk outcomes. How well did these treatments actually work? Starting with open surgery.
Outcomes are way better than the old days of ligation, which had really high stroke death rates. Modern ligation, though rare for ICA, maybe around 12% risk in a 2000 review, plus anticoagulation
And
helps.
surgical reconstruction.
Generally, the combined stroke and death risk is somewhere in the 5% to 10% range now. Cranial nerve issues, mostly temporary, happen in maybe 12% to 20%. And as we said, non-operative risks for small ones might have been overestimated before.
What about endovascular outcomes?
Early and intermediate results look quite favorable. Multiple studies report very low or even zero rates of cranial nerve injury, which is a big plus, and low stroke rates.
Any specific examples?
Yeah, using covered stent grafts for those tricky distal ICA pseudoaneurysms has shown good success in sealing them off and resolving symptoms. A comparative study looking at post-1995 cases suggested endo had shorter stays, fewer nerve injuries, and lower stroke death than open.
And for that dangerous carotid blowout.
Endovascular techniques, stents, coils, glue embolization have been life-saving in those incredibly high-risk patients, often post-radiation or surgery.
So overall, endo looks promising.
A large systematic review from 1995-2011 showed high procedural success, low periprocedural stroke around 1.8%, and death around 4.1%, and very low cranial nerve injury, 0.5%. Stent painting looked good too, but you always have to consider potential selection bias in these reviews. Maybe healthier patients got endo.
Good point. We should also quickly mention mycotic aneurysms, again, the infected ones. How is the medical management handled there?
Right, infection is key. Antibiotics are critical. You start broad spectrum, covering the usual suspects like staph and gram-negatives like E. coli, until you get culture results to target therapy.
And after surgery, which often involves removing infected material and using vein grafts.
Then it's usually a long course of IV antibiotics, maybe 4 to 6 weeks, followed by oral antibiotics for potentially 3 to 6 months, or even lifelong in some cases, though honestly the optimal duration isn't definitively known.
Finally, let's touch on kids, ECAAs in children. Any special considerations?
Absolutely. Presentation can be different. Often that expanding, pulsating neck or throat mass, sometimes mistaken for an abscess or tumor.
Symptoms.
Can be dysphagia, trouble breathing, jaw stiffness, neck pain, cranial nerve issues, Horner syndrome. But more concerningly, kids can present with cerebral thrombosis, emboli, TIAs, or even life-threatening hemorrhage from rupture.
Which is more common in kids than adults.
Sadly, yes. Mortality is high without treatment, but intervention really improves the outlook.
What causes them in children?
Infection is still a big one. Meningitis, pharyngitis, ear infections weakening the artery wall. Trauma, including iatrogenic causes like needle aspiration near the tonsil, since the ICA is close by in kids. Also congenital issues or connective tissue disorders.
And treatment in kids.
Goals are the same. Exclude the aneurysm, maintain flow. Open repair is often preferred for true aneurysms. Various surgical reconstructions are used.
What about stents in children?
Experience is growing but still limited. Big considerations are vessel size and future growth, their long life expectancy needing surveillance, and effects of antiplatelet meds. Adult stents often aren't suitable.
So, careful planning is needed.
Absolutely. Access, device navigation, it's challenging. Both covered and uncovered stents have been used successfully in select cases, but we worry about long-term issues like vessel thickening, and data is sparse. Antiplatelet use is also less studied in kids.
Sounds like the chapter gives a kind of roadmap, an algorithm for management.
Yeah, it offers a general guide based on location above or below a specific landmark and vessel kinking. Suggests open, endo, or hybrid approaches depending on the situation. It reinforces using C-TAMRA for diagnosis, lists surgical indications, and gives advice on surveilling non-operated ones.
Well, this has been a really deep dive into extracranial carotid artery aneurysms.
It's a fascinating area.
It's clear they're rare, but definitely potentially serious. Such a wide range of causes and presentations. And it's remarkable how management has evolved. Both open surgery and endovascular options are so important now.
Absolutely. The key message, I think, is accurate diagnosis with good imaging is vital. And then treatment has to be really personalized, tailored to that specific aneurysm and that specific patient.
So here's a final thought for you, our listener, to chew on. With these incredible leaps in imaging and minimally invasive endovascular tech, plus our better understanding now of how smaller aneurysms might behave, how do you think our approach to finding and treating these and maybe other rare vascular problems will continue to change? It really makes you think, doesn't it? Finding that right balance between jumping in proactively versus careful, watchful waiting, especially for conditions we don't encounter every single day,